Looks like we're probably up.
Yeah. Let me just get a brief introduction for the participants.
Ooh.
Okay. So I want to thank you all for being virtual present here, and especially for Mike for accepting this invitation. I met Mike like 5 years ago when I went to Cincinnati to that Midwest Airway course. And later then he came to São Paulo 2 or 3 years later, and I get the chance to know him better. And he's an extraordinary guy, always available, always willing to help you. And he's one of the best surgeons, of the airway surgeons that I ever met. But he got a peculiar taste for Hawaiian shirts. But that's okay. He's a very nice guy, and I hope that all of you can enjoy this meeting. And now it's with you, Mike.
Okay, sounds good. So what I'm going to do is we'll convert over to the PowerPoint shortly, and again, make this as interactive as you wish it to be. I am totally fine if we don't finish the talk. If we do, there should be plenty of time for questions. And shall we flip it over, Vitor, to the PowerPoint?
Yeah, you can share your screen now.
Okay, let's see. I should go there. Perfect.
Just
so can you see that?
The participants to don't open the microphone during the lecture, but later everyone can ask questions.
Okay, so it's up on my screen. Is it up on yours?
No, not yet.
Ah, that means I got that wrong, which is a frequent problem of mine. So I've got to go to the, that's not what I want. So where's there's the share screen. Let's try that again. And go to that. Okay, so can you see that?
Yeah.
Good. Perfect. Okay, so let's talk about the pediatric airway, and this is entitled Challenging Problems and Creative Solutions. And I'll firstly just get through the mandatory disclosure slide. And basically, I have worked with several companies. There's a stent with my name on it that I don't get royalties for because I declined them. There's a couple of balloons I've helped design, one of which I patented. I use a lot of products off-label, and so I'll move on from that. And so the theme of this talk is that surgeons are problem solvers. And I started my fellowship in Cincinnati in July of 1997. And I did the remedial stream fellowship. It took me 3.5 years to get through the fellowship because I had visa issues. And the cool thing was that Cincinnati had and has a lot of challenging cases, and you had to try and find solutions for these people. A lot of these children were being sent to Cincinnati, and if we couldn't do something for them, usually that meant that there wasn't much that could be done for them. So, and this was something that worked well for me. And so conceptually, I'm going to tell you a lot of the things, of the problems that I faced over the last 20 or so years, and some of the solutions that we thought of, and how that often propagated. And again, this does not mean that you will wish to do everything we're talking about. And even if there's only 2 or 3 things that make sense to you that you would like to do in your practice, that's still worthwhile. And so I'm just going to present you with a lot of interesting ideas, and hopefully some of them will be of some value to you. And this is really chronological. So let's start in 1998. A gentleman came to us, an adult actually, he was 50, he had a tracheotomy and a severe subglottic stenosis. I don't remember why no one would operate on it, but there was a reason. And he had a job talking on a telephone, and he was having increasing problems tolerating a Passy-Muir valve because he was popping it off. And so I tried to work out what could I do to help him tolerate a Passy-Muir valve a little bit better. I thought the best thing would be a Passy-Muir valve selling point is that it's a non-leak valve. So I tried to turn it into a leaking valve. And this is what I did. That is my Black & Decker in 1998 with a Passy-Muir valve. And I found that if you drilled a 1/16 drill bit, roughly a 1 millimeter drill bit hole in the side of it, you would create a leak. And it might make it more tolerable. If it still wasn't tolerable, you could put in 2 holes. If it still wasn't tolerable, I found that 3 holes was too much and you could only talk for 3 seconds, so it wasn't worth it. So this is a video from back then, and we modified the technique because Bob Wood, one of our pulmonologists, used to do pressure checks on Passy-Muir valves. So we then used pressure checks using an inline manometer on an oxygen adapter, as you can see here. And if you can quietly breathe at less than 10 centimeters of water pressure, you can just use a Passy-Muir valve. If it's over 10 centimeters, as you can see there, that's running about 20 centimeters, then it's worth drilling a hole. As you can see, my accent hasn't changed an awful lot despite an additional 20 years in America. Pretty sophisticated. And so I then thought, you know, that's a little complicated, it's very effective. And we do this to a lot of Passy-Muir valves. And I actually designed a 2-way valve, which is you take a 1-way valve and the peg in the center holding the diaphragm, I turned into a second valve. And, oops, I'll go back one. And so I patented this an extraordinarily long time ago. It's surprisingly difficult to make. So we still have prototypes and don't actually have a final product, sadly, but that is the ultimate intent, is to have a 2-way valve where you don't need to do a pressure check. It just does it for you. So that's a plan for the future. So let's move into 1999, retrognathia. And so I put this up because in 1999, I'd been in the hospital a couple of years and I developed the reputation of being the person who could intubate children that no one else could intubate, which is an awful reputation to have because you get phoned by everyone. And so this was particularly for Pierrot band babies. And so this is a baby who's retrognathic. And as you look down with a telescope, what you'll see in a second is that it's very hard to expose the larynx. And I was able to intubate most of these children when everyone else failed. And believe me, that is not a good reputation to have. So it took me a while to actually work out what I did differently. And there were 3 things. So I put in the anesthetic blade to the right of the midline. So it's not on the incisors, it's closer to the canine teeth. So it flattens the angle of attack. I've got my little finger on the larynx giving me laryngeal pressure, and that exposes the arytenoids. And then when I intubate, I'm using a stylated endotracheal tube with a small bend at the end of it. And the key thing here is that, if you can see my mouse, the bevel, you want the pointy bit to be anterior. So if it hits the arytenoids, it bounces forward. 3 little things, and put them together, and it means that you can intubate children who are otherwise quite hard to intubate. This doesn't mean I can intubate everyone, but it does mean that I can intubate most kids with Pierrot-Ban. And I've worked very hard to teach as many people in my hospital as I possibly can how to do this, because it's in my best interests that I don't get called to all of these. So now let's move forward to 2000. And a child was sent to us who had had a tracheoesophageal fistula, esophageal atresia repair. The fistula was quite high in the trachea, quite a lot of malacia, and so the child ended up with a tracheotomy tube. And the problem with the tracheotomy tube is that every trach change, it was a lottery. Is the trach tube going to go in the pouch, or is it going to go in the trachea? If it goes in the pouch, the child's trying to die. If it goes in the trachea, everything fine. That was awesome. So a couple of videos. At the top, you can see a classic tracheoesophageal fistula pouch tied off at the end. And you can see how during a trach change, there would be a risk that the trach would go into the pouch, because the trachs often want a back wall. You can see the same thing here at the bottom. And so the key is, how can you get rid of the pouch? So one option is to take a cautery or trichloroacetic acid and just demucosalize it so it scars away, but it's a little unpredictable. And so what I did was that I actually found that there were some laparoscopic instruments that, if I borrowed them from the pediatric surgeons, they were very effective. So this is a Storrs click line biopsy forceps. It's got suction, it's got cautery, it's like a true cut that you would use in the nose. And this is how we used it. Telescope in through the trachestoma. There's the click line biopsy forceps. It's touching a lot of tissue, so usually you crank up the wattage on the cautery to about 50 watts transiently, try and lift and just cauterize that common party wall, and then click through it. And you just keep doing that till you get to the bottom of the pouch. And so you're marsupializing the pouch, and you can do this really quite fast. And you can't have a trach tube going in a pouch when there isn't a pouch there. And it's quite useful at improving tracheomalacia as well. And so this is the same child about a month later. They still need a trach tube, they've still got a lot of malacia, but the pouch is just eliminated. And that was where the pouch used to be. So also in 2000, we deal with a lot of children with tracheotomies. We did a lot of surgeries to help their stenosis. Often they were 2-stage, so you've got a trachestoma. And we found that when we were doing tracheocutaneous fistula closures, if we did a layered closure, in 1 to 2% of cases, there'd be an air leak. You'd get subcutaneous emphysema. In a couple of kids, we saw pneumothoraces. And so we decided that there was an alternative way to do this without that risk. And that was to de-epithelialize the tract. Again, skin is a non-stick surface. If you take out the skin tract, you've got raw surfaces and they almost always heal. As the child's waking up, they may be coughing, and to prevent that causing subcutaneous emphysema, we actually put a tiny trach tube in the hole for 1 hour and then wake the patient up, take out the trach, send them home the next day. So here's an example. Here's a girl with a Trachyocutaneous Fistula. This is with someone bronching her. I just put that in because the lighting effects are really cool. And we do a very narrow excision. This is not a plastic surgical procedure. And we apple core out the skin tract, remove the skin tract, and this is what you're left with. You can see the trach tube, the endotracheal tube in there. We then put a trach tube in for 1 hour, wake the child up, take the trach tube out. Our closure rate is about 99%, and our subcutaneous emphysema rate is approaching 0. And so it's been very simple, very safe, and if it still recurs, you can do it a second time, and that will usually work. And so very simple, quite effective. So now we're going to move into 2001. And this was the advent of the slide tracheoplasty for us. Now, the slide tracheoplasty is not my idea. We took it up. We've popularized it. We've extended the implications, and we slightly changed the way it's done. And so in 2001, our outcomes for complete tracheal rings really weren't very good. I think they were as good as anyone else's. They just weren't very good. And so this girl, and again, remember this girl, because we'll talk about her a bit later on. She is our very first slide tracheoplasty. And so this was April the 12th, 2001. Interestingly, at the moment, we're having riots in Cincinnati. And that day, we were having riots in Cincinnati as well. We finished at about 10 p.m. at night. And when I drove home, I was the only car on the road at any point. It was a very unusual experience. And so we did a slide tracheoplasty on cardiac bypass. Peter Manning, my cardiothoracic surgeon, and I extubated 2 days later, and she did well. And it was the term is a watershed event. It changed the way we did things. Every single child since then has had a slide who had complete tracheal rings. And I'm going to take you through some of the modifications that we've done with this procedure. So, and this is an old slide, so pre-op, post-op. We've actually done about 200 slides at the moment, or rather more than that. If I look at a group of children who had complete tracheal rings and no previous surgery, most of that group of 75 kids were done on cardiac bypass. If the upper 2/3 of the trachea are involved, but the lower third isn't, and their heart is okay, you can actually do this through the neck. And so on cardiac bypass, you deflate the heart, you deflate the lungs, and it's a very versatile operation. The longest slide I've done has been from the end of the left bronchus to the cricoid. I've slid into the cricoid in some children. You can slide down a bronchus. You can do an inverted slide. You can slide past a pig bronchus. It's very forgiving. And so you open the chest. This is a child with a focal distal tracheal stenosis, which you can see there. Cannula in the right atrium, cannula in the aorta. Try not to make a hole in the heart, because that's always embarrassing. Use a flex scope down an ET tube to needle the airway there so you know where the top ring is and the distal ring is. If the distal rings are on carina, you don't need to do that because you know where carina is from the outside. Transect roughly in the middle of the stenosis, and a slide means you slide one end over the other end. So this is what this is trying to show you. Mobilize each end. You split the head end at the front, as you can see there. You split the foot end, the distal end, at the back posteriorly. And so let me take you through some of the nuances of what we've done over the years, what we've learned. And this was each one of these things has been learnt on a specific child and then carried into other children. We no longer transect the trachea in the midpoint of the stenosis. We transect slightly north, slightly on the head end, and do a beveled cut over 2 rings. And the reason for that is that when you're doing the slide, your proximal segment is being stretched and your distal segment isn't. And if you're not paying attention, you can end up running short on that distal segment as you sew it up, and that's a problem. And so if you transect it slightly north of the midline on a bevel, you buy a bit of length with the bevel, and it also means you're not going to run out of distal segment as you're sewing it up, and you can always split through another ring and slide it a little further up the trachea. We found that it's better to split the head end at the front and the distal end at the back. It's easier to sew it up. And you can run it all the way into the anterior cricoid. You can go down a bronchus. You can slide into normal trachea. You can slide past a pig bronchus. All of these things we learned for patients with particular problems. And so again, don't slide in the midpoint of the stenosis, slide slightly north, do a beveled cut over 2 rings. And you split the back wall distally. I have once slid into the posterior cricoid. It worked, but I won't do it again. It wasn't a good idea. Sliding into the anterior cricoid is easy and low risk. The only advice is don't just split the cricoid, take a little V out of it. It's easier sewing it up afterwards. I have slid down both bronchi. You can do it. It's complicated. Most of the time, if you can get the trachea right and you can get one bronchus right, they're going to do okay. And so if you are very good at what you're doing, you can try sliding down both bronchi, but I've only ever done it once and I don't feel a strong need to do it again. And I actually think it's a good idea to slide slightly into normal trachea at the proximal end as a general rule of thumb. And particularly if you've got a pig bronchus, I think you have to slide at least 2 rings proximal to the pig bronchus into normal trachea, or you get a residual stenosis at the pig bronchus. Now, interestingly, the slide tracheoplasty, when we started doing it, you know, clearly it's so much better than a pericardial patch or anything like that. And we started propagating this. We told everyone that this is a great operation, and it is. The thing we've learned, because we tend to be a service that sees other people's problems, is that it's actually a learning curve, and it is a little bit surgeon dependent. So it's like a cricotracheal resection, also a surgeon dependent operation. However, this is a really easy operation to do simulation on. So whether you've just got a piece of anesthetic tubing and you pretend it's a trachea, whether you go to your local butcher and get them to give you a trachea, this is an easy one to practice on. Now, interestingly, that very first child that we did a slide on, baby MH, developed what we now call a figure 8 trachea. So when you do a slide, what you want is E, what you often get is F, and what I've termed a figure 8 trachea. And I'd never seen one before, this girl. And she had a very slightly narrow cricoid. So anything I put through her larynx did nothing to her trachea. So I couldn't dilate this figure 8 with a bougie. And because of that, I wondered whether it might be worth trying an angioplasty balloon dilator. And because I could get that through the cricoid and then dilate it. I'd never heard of anyone doing that at this point. And I actually went to the autopsy suite and tried to explode the trachea on 2 cadavers. And I wasn't able to. So I figured, okay, this must be safe. So I balloon dilated this girl. She was the very first balloon dilation. So this was around about May 2001. And now I know that figure 8 tracheas get better on their own, but I didn't know it then. And it worked well, and you start to, you know, think, gosh, I wonder what else this might be useful in. And so we're now 19 years later. Airway balloon dilation has been widely adopted. We've developed balloon dilation guidelines. We're often doing augmentative procedures like scar division and steroid injection when we balloon dilate. There are the 3 most common non-compliant balloons. 1 is not licensed for the airway, 2 are licensed for the airway, and I helped develop one and I designed and patented the other. So again, in terms of disclosures, you need to know that. And so the good things are radial dilation. There's no shear forces. These are high pressure balloons. They are low risk. The disadvantages, they're expensive and they're slippery. And so the technique, we put the balloon in under direct vision and pre-oxygenate the patient, give them a burst of propofol, diprofan, then inflate the balloon. I usually put the balloon up for 2 minutes because you keep adding water to the pump for about 90 seconds as the stenosis gives, or till the oxygen saturations drop to 90%, whichever happens first. Then deflate the balloon and remove it. And I've done a lot of balloon dilations, and it's always worth, you learn a lot from your own complications and from other people's complications. And I'm going to show you my worst complication, balloon dilating. And as with everything, this doesn't work for everything. And so I've developed guidelines, and these are experience-based. And so a 4-year-old should take a 5-0 endotracheal tube. The outer diameter is 6.8 millimeters. And I add 1 millimeter for luck for the larynx and 2 millimeters for luck for the trachea. So I'd use an 8 millimeter balloon for the larynx and a 9 millimeter balloon for the trachea. And having to think about things is challenging. So I printed this out on a piece of paper and stuck it up in our operating room. And our fellows, all they had to do was turn around and look at it, and it told you what size balloon to choose. And obviously, you know, my fellows are millennials. That's a tough ask. So we developed an app. And so this is free. Most of you have it already. If you don't, just go to, you know, the App Store, and whether it's an Android or an iPhone, it's free and it's worthwhile. Now we're trying to actually work out the right implications for, you know, what are the indications, to actually put some science in this, because this has all been experience so far. And this is Claudia Schwager with her stridulous rabbit. And this has been something where we're trying to actually develop guidelines that are more scientific than just experience. So let's go to 2003. I mentioned that balloons are slippery. This is my big complication. And so I had a child who had a slide tracheoplasty. He stenosed distally. You can see the edges of the slide. Don't know why he stenosed. That's quite unusual. Balloon dilated him a couple of times. On the third time, the balloon slipped into his right main bronchus, which was also a bit stenotic. And this is what happened. So that's the balloon after it slipped, or when it was about to be inflated and slipped. And this is what it did to the right main bronchus. So that's the bronchus, and it's got a big hole in the medial side, and that's pericardium. So bronchus, pericardium. And again, this child's had an open chest procedure recently. Everything's walled off. They're not going to get an air leak. They've just got a big hole in their bronchus. And again, this child did fine. They healed. They had no problems at all. We didn't even intubate them. But it made me sit up and take notice. Slippery balloons can have consequences. And so I designed a non-slip balloon. I figured that if I put a surface coating on it, the balloon would move anyway and it would just act like sandpaper. So my concept was that either end of the balloon would inflate first, and then the center of the balloon would inflate to dilate the stenosis, having already been gripped by the outer balloons, the hubs. And so this is the balloon inflating, and you can see how the outer hubs grip first to try and minimize the risk that the balloon is going to slip. And then the center inflates and actually does most of the dilation. And so this is the very first human we used it on, and a very nice cartoon of a slipping balloon. That was what we tended to have as a problem. And the cartoon then shows the concept of the non-slip balloon here, where the outer hubs inflate and then the center inflates and does most of the stenosis. It looks great on a cartoon. And I wanted to call this balloon-assisted dilation airway safety strategy, or the badass balloon. And I'm still extremely disappointed that the company I'm working with wouldn't allow me to do this, because personally, I would buy a badass balloon in a heartbeat. So we were talking about the same baby. So she's the first slide we ever did. She's the first balloon dilation we ever did. And we saved her life. As surgeons, we have the opportunity to make a real difference to a patient's life. Occasionally, a patient will make a real contribution to clinical practice. And it's very unusual that the same patient does that twice. And this girl, we did something life-saving for her. And as the first slide we did and the first balloon dilation we did, she's had an immense contribution to airway surgery. And this is her. This is her when we did a slide. This is her trachea a couple of years ago. And this is her as an 18-year-old high school senior. She's doing well academically, she's symptom-free, she's a cheerleader. So 2002, we could no longer get Teflon suprastomal stents, the old Albudka stent or Cotton-Lorenz stent. And the problem with them as well was that they caused granulation tissue distally if you left them in for very long. And so this is an old Teflon stent. When you take it out, this is the suprastomal area because the cut end really was irritating. And we could no longer get anything Teflon. It went out of fashion. And so I designed a suprastomal stent that was silicone, soft, that this is not sophisticated. So Fleet-Monnier stent is sophisticated. This is cheap and simple and effective. You cut it to the length you want and you put a cap on the top. So you just choose the diameter. You don't need to have a range of lengths. And this is, let's try that again. And so we can usually put them in open when we're doing an open airway operation, but we can actually also put them in endoscopically. And so this is just a little video of that, I think. So let's move on. Nebulizing saline. And so almost all hospitals basically poured scorn on this concept when I was a fellow. And I had a girl in 2003 intubated for complete tracheal rings. And that's a bad combination because you tend to mucus plug. And if you mucus plug in a segment of complete tracheal rings, your CO2 steadily climbs, you'll still oxygenate, and then you'll crash. And so we had a girl where we had to intervene repeatedly to clean out her trachea. And I insisted that we started nebulizing saline while the child was intubated, or putting saline down the endotracheal tube, or in children who weren't intubated with a tracheal stenosis, that they should have saline nebulizers. And it's become an integral part of what we do because it allows the patient to cough out their own secretions by thinning them out. Something very small, but it's made the perioperative care of these children much safer. Also in 2003, we did a slide on a boy who also had a tracheoesophageal fistula pouch. This is this video. Nicholas, pre-op, post-op. And you can see he's got a TEF pouch at the back, and he's got a segment of complete tracheal rings at the front. And we had to do a slide, and we couldn't ignore the pouch. And this is after we fixed the pouch and the slide and the tracheal rings at the same time. And so we then started to do slide tracheoplasties for challenging tracheoesophageal fistulas. I've done about 30 of these, and these are usually done for difficult cases. And so here's a girl, she's 7, has Down syndrome, had a type C TEF repaired on day of life 1, kept getting pneumonias, lots of bronchs and swallow studies. So we're looking for a laryngeal cleft. She's got a little bit of a deep notch, but not truly a cleft. And then you go and have a look around. You can see there's some secretions there. There's something suspicious there. I've got my forceps in her esophagus, and I'm just probing with an open alligator forceps, and she's got an H-type tracheoesophageal fistula. They're really easy to miss. Now, these are not easy to fix endoscopically. They look really tempting, but I'm just going to tell you with the voice of bitter experience that it usually doesn't work. So I now do slide tracheoplasties on these. This is her esophagoscopy. I put it in there just because it's cool, because she's got a retroesophageal subclavian artery, as you can see right there. It's just a pretty picture. I just thought I'd put it in there. And so the slide tracheoplasty, I think I'll blow through that. So the modification is when you've got a tracheoesophageal fistula, transect at a right angle above the fistula, transect at a bevel down to below the fistula, as you can sort of see here, and you end up with 2 wings of trachea attached to the fistula. And you can use these to repair the esophagus. So it's viable, vascularized tissue that's strong. It's got cartilage in it, and you can fix even quite a big hole. I've been able to use this technique to fix holes that I could stick my thumb through. And so this is her just transecting her trachea just above the tracheoesophageal fistula, and you can actually see the tracheoesophageal fistula there. And then we'll go on and do a slide. And that's the airway in 2 pieces. Usually worth putting a stitch on distally because it sort of shoots off into the distance. And this is her post-op. Her lungs were so damaged, it took her 2 years for her lungs to fully recover. And for 2 years, she still looked like she was aspirating when you did a bronchoscopy. And now we're 5 years out and she looks perfect. No secretions at all. So moving forward, 2004, as you can see, back when I was younger, I used to have a good idea about once or twice a year. As I'm getting older, it's happening less commonly. And so I had a girl who had a terrible tracheal stenosis following an intubation for a motor vehicle accident, and someone put in metal stents in her airway, and she was re-stenosing through them and got a tracheotomy through the metal stents. And I actually removed the stents in the operating room open, and it was extraordinarily difficult. I was literally ripping them out wire by wire, and it looked like I might rip her trachea in 2. My fellow at that point was Diego Preciado, who was looking very green while I did this, and I was actually slightly concerned he might throw up in his mask, but he persevered. And interestingly, she had terrible granulation tissue afterwards. So for 4 weeks in a row, every week she'd come back with 3 days of significant symptoms, and I would clean out a lot of granulation tissue, and this is beyond where her trach tube was. And then she'd be good for a few days and she'd come back terribly and life-threateningly obstructed. And I thought, how am I going to deal with this granulation tissue? And Ciprodex had recently been introduced as an eardrop. It's a steroid, dexamethasone, 1 milligram per mil, and a quinolone antibiotic, ciprofloxacin. And so I got her to start putting Ciprodex down her trach tube. And she came back a week later, and it was frankly miraculous. And that one girl meant that I started using Ciprodex for a lot of things, and it's become a mainstay therapy for a bunch of the things that we do. And metal stents can be truly challenging. So here's a wall stent. So the technique I use when I'm removing these endoscopically is you get a heavy forceps, a strong one. You try and get one flange under the metal, one flange in the lumen. Then you disconnect the camera, disconnect the light source. You wind this thing up about 5 times and you rip and pull it out. And there's blood and wire everywhere. You need to have a sympathetic anesthetist when you do this, because this can be quite frightening. And again, Ciprodex is something we use a lot of at the moment. And so if you've got a trach tube and you've got any bloody secretions from your trach, or you've got tracheitis with Pseudomonas, 3 drops 3 times a day down your trach tube for a week. We use it when we take a stent out. We use it whenever there's granulation tissue. We use it on the outside of trach tubes to wick down the outside if there's granulation on the skin. We use it around G-tube sites if they've got granulation. We use it in the nose following a choanal atresia repair or a FES. And so it's been very useful. it's expensive, so we found if you get 2 bottles of the components, a bottle of dexamethasone drops and a bottle of ciprofloxacin drops, it's much, much cheaper, and you can mix them together. So 2004, this was a child who had a fenestrated, who we tried to fenestrate a trach tube because they were failing decannulation. And we went through 5 trach tubes because we couldn't get the hole in the right place. And so the idea I had was to get a Sharpie, an indelible marker, and write numbers down the side, put the trach tube in, and you can see exactly where to make the hole. And I usually use a sphenoid punch to do this. That's fenestrating a trach tube. And you can see exactly where to put the hole fenestrating if you use that technique. Very simple, doesn't waste tubes unnecessarily. 2005, endoscopic tracheoesophageal fistula repairs. This is a child who had had 3 open repairs and nearly died on the 3rd, and still had a fistula. And he had had a pneumothorax, he had had an empyema, he had had an esophageal dehiscence. He's got a little bit of malacia. He's still on our neonatal unit, and he's got a fistula down on carina. And this is sort of sucking it out. And what I'm doing here is there's suture material buried in the bottom of it. I'm pulling that out because, again, like a tracheocutaneous fistula, you want to demucosalize. So you've got left bronchus, right bronchus. You can see esophageal mucosa in the TEF. Mucosa is a non-stick surface. You have to get rid of the mucosa. You can use trichloroacetic acid. I prefer to use a Bugbee cautery, but it's whatever tool works for you. The aim is to remove the mucosa. If you can get one raw surface against another raw surface, you've got a decent chance it'll stick. Oops, let me go back and go there. And so this is then using a Bugbee to cauterize the tract, taking out the mucosa, putting in a little bit of fibrin glue at the end just to seal it. And this is the same child about 6 weeks later. And it really genuinely is the same child. You can't even see where the fistula used to be. So a nuance on that, what we're finding is the key is you want to get raw against raw. And often you're having to do this 2 or 3 times. And what we found is that if you inject a filler like Radiesse gel or Prolarin gel right beside the fistula after you've deepithelialized it, you're more likely for it to close on one attempt. And so in the interest of time, I'm going to go a little bit faster here. So we've got the fistula. We're going to Bugbee cauterize it. You could use trichloroacetic acid. Oops, I didn't mean to do that. Sorry. Let me go here. And this is trying to inject some Prolarin gel. And again, this is actually quite a tricky thing to do down usually a neonate's airway. So this is voice gel and just putting enough to not occlude the airway, but to occlude the tract. So you need a very small amount. And this is the child about 6 weeks later. And that's where the fistula was, and it's just completely ablated. In 2005, I had a girl with complete tracheal rings in the middle third of the trachea, no cardiac defect, and I thought, why do I need to go on bypass for this? And so she was the first cervical slide. Mobilize the trachea. This is actually an acquired stenosis, but it's the only video I could find. Transected through the stenosis. Split it open. Multiple throws of a 4-0 PDS. Tighten them up. And keep running the suture. As you tighten it up, that's a cervical slide. And we now have stopped doing tracheal resections. We do slides. Even a short segment slide has got a longer, more oblique suture line. So here's a girl who's had a lot of surgery. Pericardial patch cricrotracheal resection, LTP, 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 tracheal homograft, and an endoscopic stent, still stenotic. I did a slide, extubated her on the table. She has had no problems for the last 12 years. She returned to Hawaii 12 days later, and I get pictures sent from the family, but she's never needed to come back. So as even for challenging cases, this can be a very good operation. So 2006, child with a chronic esophageal foreign body, a coin, which was hard to visualize. I changed my esophagoscopy technique. So normally I'd use an esophagoscope, visualize it, then put down a foreign body forceps. The optics aren't great. Often there's a little bit of bleeding or secretions that get in the way. And this was how we standardly took out coins. And so I thought, why am I using an esophagoscope? Coins are almost always right at the top. Why didn't I just put my anesthetic laryngoscope blade through cricopharyngeus? And so I'm placing, the child is intubated, the blade is behind the larynx through the esophageal inlet. As you can see, this is a really old video when at least some of my hair was still black. Grab the coin, pull out the blade and the coin together. I think my current record is 6 seconds. And so usually now we'll put the blade in, have a quick look. Yep, that's what we're dealing with. Make sure it's not a button battery or anything. And I usually just go straight in with the coin removing forceps. It's not particularly sophisticated. Once the coin's out, you can get a really good look around the upper esophagus first. Once you're beyond thoracic inlet, it can be a bit collapsible, but you can get an excellent visualization of a lot of esophagus using this technique. And of course, the optics are superb because you can use a bigger telescope. And so these are a couple more. So the limitations, once you pass thoracic inlet, this is not so great a technique. In an older child, it's hard to find a blade that's long enough. But otherwise, very simple, very quick. 2007, so we're slowly moving forward in time. And I had a girl with a type 1 laryngeal cleft that had been repaired endoscopically in layers, and this is what we had. It hadn't quite worked. And so this is what I did. I decided that I am not patient enough or competent enough to do a 2-layer closure. I decided to do a mass closure technique. Take out a broader piece of mucosa and do a mass closure. And we'd always release the aryepiglottic folds at the same time. And so This is her a few months later. It worked very well, and it was relatively quick and simple. And so this has become something that our fellows have become very good at because it's reliable, simple, and fast, to the point it's almost diagnostic. If you're not sure, it's quick enough and benign enough that we'll sometimes just fix it and see if it helps. And so this is one of my then fellows, Chrissy Hybe, and you do, you know, one snip tines in mucosa, one snip tines in the raw area, and you go an incision on the upper layer of mucosa, an incision on the lower layer of mucosa. You go down to the apex of the cleft and take out that V of tissue. You can do this with a laser as well. I prefer to do it with scissors. It's just whatever you're most comfortable with. And then stitches front to back, right beside the cut mucosal edge. Sorry, back to front on the left, then front to back on the right. And remember, you need to do multiple throws with PDS, at least 6 throws, and then release the aryepiglottic folds afterwards. I'll move forward from that one. So now we're going to get to 2008. I had an idea for a new operation for type 4 class. And I needed a new operation because we were doing so badly with the operations that we'd been previously doing up to that point in time. Type 4 clefts were bad, and these kids tended to die late, and it was just not nice. So I developed a new operation, and this was basically what I did. I developed a transection technique where I transected the trachea off the lower border of the cricoid, peeled the trachea off the esophagus till I was beyond the apex of the cleft. Then I was looking down onto the esophagus. I could repair that, going back up into the larynx, put down an interposition graft. I could repair the back of the trachea and then reattach the trachea to the cricoid. Single stage it and do a late tracheotomy 2 or 3 weeks later. Sounds complicated, but it's a whole lot simpler than what we used to do. And so here's an example. This is a girl who was sent to us in 2006, 2.3 kilos, microgastria, and she's got a cleft. So this is her bronch. As you take out the endotracheal tube, this is quite a big cleft. So that's the right bronchus. That's her esophagus. And this cleft goes to the very end of the left bronchus. That's the left upper lobe. And if that's the left upper lobe, there has to be a left lower lobe. You've just got to go and find it. And that's the left lower lobe. And so the standard techniques used before this would not be adequate to repair something like that. And so we actually grew her till she was bigger. We waited 3 months till she was over 5 kilograms, kept her airway clean, and a team of people cared for her. And we basically did that operation. And this is her something like a 1.5 years later. She still has a trach. I've still got to fix her larynx because it's too narrow, partly because of the very high trach she needed, because she had a short trachea. But her trachea is intact. The left bronchus is still a bit challenging, the left lower lobe anyway. But she's done well. She's got a normal brain. She's a cute kid. And eventually I will get her trach out. I just haven't done it yet. So move forward to 2009. I evaluated a 10-year-old with severe recurrent croup. And I thought, I don't like doing LTPs on kids with a normal cricoid. What can I do to stop the swelling that we're getting in the subglottis when this kid gets croup. So I thought, scar tissue doesn't swell, let's scar it. So I used a Bugbee cautery, and I deliberately did a series of pinpoint burns right round the cricoid. So when it swells, these areas will stay pinned down. And we've recently published a paper on this, and it's actually, I only do this once or twice a year. It's not many kids who need it, but for the right kid, it actually works very well. I preserve mucosa between each of these burns, and when this child gets an upper respiratory tract infection, these areas don't swell, and the bits between them can't fully swell because they're pinned down by these areas, pin cushioning the subglottis. The anterior posterior cricoid split. So this was 2011. I decided there had to be a better way of dealing with vocal cord paralysis in babies. And most of the time we were tracheing and waiting at that point in time. So I developed the anterior posterior endoscopic cricoid split, which you can see here. This is now splitting the anterior cricoid. It's surprisingly easy to do this operation, usually balloon dilating at the end just to pop everything open and leaving them intubated with a big tube for 10 to 12 days. And it took that long for the posterior split to fill in. And basically, this doesn't work for everyone, but we've had about a 70% success rate in avoiding tracheotomy in kids who would otherwise get a trach. Now, why is my, here we go. And so I'm going to talk about one last thing very briefly in the interest of time. So 2016, this was the idea I had for helping children with pharyngeal stenosis who have a trach. And so pharyngeal stenosis can be really challenging. And so, and again, here's a child who's got a grade 4 stenosis. Their pharynx is utterly blocked. You can't find the larynx. Caustic congestion. And so unzip everything. Sorry, let's see if I can make this work a bit better. So you're dividing scar tissue. Obviously, you have to be cognizant of where things like the carotid arteries are. But the problem is, you get all these raw areas and you can't swing in tissue flaps because everything's scarred. So you've got to hold the raw areas open while they remucosalize. So my idea was to place an endoscopic suprastomal stent that was so high, the top of it was basically above the uvula in the nasopharynx, and then wrap a Swiss roll of silastic around it in the supraglottic pharynx. So you can see I've attached silastic sheeting around that, and you can either put it on one side or you can actually that video is not running. Let's try that again. It's jammed on me. There we go. Whoops. Sorry. I think I'm getting to the end of the talk because the talk's objecting. So that happens. And so you've got silastic there, wrapped on the outside. And a year later, we've actually got an airway we can work with that's open in an open pharynx. So again, that video won't run. Sorry about that. life goes on. And so obviously the talk is sort of running out of cash. So hold on a second. I think there's going to be a slide that turns up here. Let's just see if I can get out of that. Well, I think that was pretty close to the last slide anyway. So any questions?
Okay, thank you, Mike, for your excellent presentation. Now I will open to discussion, and if anyone wants to ask any question, please feel comfortable to open your microphone and your video. And first of all, I would like to ask about your decannulation protocol in Cincinnati. How do you guys work it out?
So we have, we usually decannulate maybe 50 children a year, something like that. And so we've got a fairly set protocol because, again, some things work quite well as a protocol, and it minimizes the risk that something, you know, unfortunate happens. So typically what we'll do is, if we do a bronchoscopy and we think the airway is adequately open, we will put in a very small trach tube, plug it, watch the child in the hospital 2 nights, and if they do well day and night, they go home with the trach tube plugged off, ideally with a saturation monitor available at night. And if there's no other concerns, they come back about 6 weeks later. If there are concerns, and there are sometimes that, we've done this for sometimes a year if there's secondary reasons for doing it. But most kids, 6 weeks, come back, have another look in the operating room. If it still looks good, then when they're fully awake afterwards, we take out the trach, watch them 2 nights, send them home, bring them back 6 weeks later. If they have a tracheocutaneous fistula, and about 50% will, then another 6 weeks later, to let it shrink as much as possible, we'll then do an operation to remove the tracheocutaneous fistula. So it's a step by step by step. You've got to earn it so that we minimize risk. And again, these are guidelines. You alter them according to the individual needs of the child or the individual circumstances of where you work. But that's what we do as our protocol.
Perfect, perfect. Thank you. Anyone want to ask any questions?
That was easy.
Can I ask something, Victor?
Of course.
Yeah.
Let me put my video on. Hi, Mike.
Hey, Rebecca, how are you?
Fine, love to see you.
Good to see you.
I wanted to ask you, what's your preference when you're talking about slide tracheoplasty, sliding small bits of the trachea, like for a tracheoesophageal type H fistula?
Yes.
What is the advantage of sliding a tiny bit of trach instead of doing an end-to-end?
So the advantages are that if it's oblique, you get a longer, more detensioned suture line. And so with an end-to-end, you've always got the risk of a bit more tension on it. With a slide, you detension it. And I tend to use a running suture technique, which I think also actually evens out the tension across a repair. And so we've found that, you know, we're able to do much more challenging or tackle more challenging problems using that sort of technique. And so I did one last week. I haven't even done the post-op bronch yet. I'm actually probably going to put his video in a talk on Friday this week, actually, once I've actually bronched him on Thursday. And so what I found is that the other advantage is you don't need to remove all the stenosis. If you cut out or you transect on a bevel, you can transect on a bevel and excise about 1/3 to 1/2 of the stenosis, slide the rest, and as long as if you're sliding a scarred bit of trachea into a good bit of trachea, you get away with it. If you slide scar on scar, you've got a much higher chance that it'll re-scar and be a problem. But it means that even if you've got a long stenosis that would be difficult to deal with as an end-to-end anastomosis, you can actually do something that's got a more detention suture line, oblique suture line, and leave a little bit of scar behind, because again, if you slide scar into normal trachea, it's going to do okay. So we've virtually abandoned straight tracheal resections, interestingly.
Okay, my doubt was with the tension, even with a small segment, but then, yeah, so I suppose you can leave some disease too.
Yeah, with a small segment, it doesn't matter. You can just
well, yeah, okay. Thank you.
Anyone else have any questions? Oh, I see there's a whole bunch.
I think Pato Varela has his hand up.
He's a raised hand, but I don't know if it...
Yes, I'm here trying to...
Yeah. So, oh my goodness.
Can you hear me?
Yes. Yeah. I was just looking at these sort of 10,000 comments coming through. I'll try and read those later. So they don't seem to be questions. So.
Yeah. Congratulations, Mike, for your lecture and nice pictures. Regarding the recurrent tracheoesophageal fistula, in the first case, we saw very well the technique. You are using the cautery and then a glue, but I didn't see very well the second video. Can you explain again? Did you perform the same technique or you did something different?
So we did the same technique, but we found if you do an endoscopic demucosalization, trichloroacetic acid, Bug-B, that we had a recurrence rate and that we often had to do it 2 or 3 times. And that we found if we could inject a temporary filler, so this is what laryngologists use to bulk up vocal cords. So Radiesse voice gel, Prolarin voice gel, they last for a few weeks. And if you injected it submucosally just beside the fistula to sort of squash it shut, and you ended up pushing one raw surface against the other raw surface, your percentage closure rate went up significantly. The only problem is it's really difficult in some children to get the needle all the way down to the fistula. It's usually you can do it, but sometimes you just have to give up and discuss. It's just technically slightly difficult to do. So, but that's what we do when we're able to.
Okay, I have a second question. Can I go with the second question?
Go ahead.
I mean, who's going to say no to you, Pato?
Yeah, but sorry, is there another question from the audience or not? I can't wait for the...
Oh, no. This is all about you. So.
No, I want to back with Rebecca's question again. So what are you doing in your center with the tracheal stenosis, the post-intubation short tracheal stenosis? Do the residents start with the tracheal resection and end-to-end, or they go straight to the slide tracheoplasty technique?
Yeah, we do many slides, even if it's only over 3 rings. Even if it just means that you're, splitting the proximal end as a little V across a couple of rings, and slightly splitting the distal end again as a V to tighten up the trachealis, that you end up with a running suture, oblique suture line. And it's amazing how well it comes together. And so I don't think I've done a tracheal resection in 10 years at this point.
Did you have any morbidity doing a tracheal resection in short stenosis?
Yes. We've, I mean, one of the videos I commonly put up in balloon dilation is where we've got an anastomotic web at the resection site. And so, again, some people, if there's any tension across an end-to-end anastomosis, can develop a mucosal web in that area and restenose. And so, again, we only get sent other people's problems, so it's hard to know the numerator and the denominator. So I get to see things that have gone wrong. I don't always know how many things went right, and so it's very hard to know. I can't give you a percentage, but I know I've seen at least a few of those.
Thanks, Mike. I have more questions, but I will keep for Friday.
Okay,
Thanks a lot.
I have one
Hello.
question that sent me to the WhatsApp.
Jose.
Can I go? Yeah.
Vitor, posso fazer uma pergunta para o Mike? É o José Lubianca de Porto Alegre.
Go ahead, Lubianca.
Okay. Hi, Mike.
Good to see
Thank
you.
you for your excellent presentation, as always. I have a question for you. For the type 1 cleft, okay, do you try the injection first to do a therapeutic test, or you go directly to suture it?
So, I mean, it's interesting. So basically, some of my colleagues like to put in a temporary injection, be it, you know, gel foam, fat, radius, whatever. I'm of the view that if that works, it will then go away. Your problem will probably come back, in which case you'll be doing a repair. And if it doesn't work, you're not quite sure whether it was a problem with that or not, and you'll probably do a repair. So I tend to just go ahead and put in a couple of stitches. And again, my rationale is that it's become, for us, a first-year fellow level operation. It's not a tremendously difficult thing to do. And because of that, I'm much more comfortable just putting in 1 or 2 stitches.
Okay, thank you.
Okay, I will ask a question from my colleagues that send me through the WhatsApp, and I will back to the decannulation topic. What do you think about downsizing the trach cannula, and what do you think about pulmonary respiratory function test?
So whenever we're doing a decannulation trial, we're trying to do it with a trach tube that does not obstruct the lumen. So usually a very small tube, and a young child will go as small as a 2.5 if need be. In terms of what ancillary tests do we do, usually it's actually not pulmonary function tests. In some children we'll do a capped sleep study. And usually I think if you're going to have problems, it tends to be more at night than during the day. And I think that a capped sleep study probably gives you better information than a pulmonary function test gives you, personally.
Okay, thank you. Any more questions?
I'll have a look at the chat and see if any of those are questions.
Yeah, there's a question about vocal fold paralysis, about
Yes.
your procedure. Do you prefer to use the grafts?
So again, I mean, this is a fascinating area, and it's one of those things that one of my senior colleagues who's just retired, Robin Cotton, who's a good friend, and we see eye to eye on a lot of things, and we've never seen eye to eye on how best to manage vocal cord paralysis. And so generally speaking, I like to go first in someone who needs something done to a posterior graft, whether it's endoscopic or open. And if that fails, then I tend to do a vocal cord lateralization. Whereas Robin was the exact opposite. He tended to go vocal cord lateralization, and if that failed, then you'd think about a posterior graft. And thrown in the mix, you've got posterior chordotomies, arytenoidectomies. All of these options can be open or endoscopic. So multiple options. My own go-to is a posterior graft, whether it's endoscopic or open. And you're trying to preserve voice and trying to minimize the risk of aspiration.
Perfect, thank you. I think we are kind of done with the questions here, right?
It's great to see everyone. So,
Yeah.
well, I can see some of you anyway.
I will ask everyone to open the camera just to take a nice picture.
Well, it may be that some people really don't want us to see what they look like at the moment.
And again, Mike, it was
well, clearly Pato is one of them. Yeah, at the moment, I'm guessing that Pato is stark naked drinking a margarita. So, yeah, definitely don't open your camera, Pato. So, well, it's really good to see everyone. Again, be safe out there. Let's hope that normality returns to our lives soon. And again, this talk was done as a, even if there's one or two things that might interest you from this talk, then it was worthwhile. This is not designed to be a, you know, this is what you need to do. This is a series of suggestions, some of which might be of value to you. So, best wishes, be safe. Thank you for the invitation. Some of you I'll see on Friday.
Congratulations, Mike. Tanya, from Tanya.
Tanya, good to see you.
Congratulations. Bye.
Thank you all for the presence, and see you guys next week. Next week, we're gonna be back in Portuguese. Thank you.
Okay, thank you, Mike.
Take
Bye-bye.
care, everyone.
Thank you.
I'll
Mike.
sign off at this point. Best wishes. Bye-bye.
Thank you, Mike.